he had 162 slides on this thing. And I was like, thanks, Dr. Pandia.
All right, you're on.
All right. Hey, guys. So my name is Jeremy. If you haven't met me or seen my name on any notes or run across me over the last couple of years, I've been here for 4 years now. Been working in the orthopedic department. So a friend has been asking me to come and speak with you guys for quite some time now, and so here we are. We're going to go over a lot of the pediatric fracture stuff. There's a lot of slides, so we're going to move pretty quickly through it. There's also a number of slides that are, this was initially for orthopedic residents, so there's a lot of slides that actually have to do with like the actual surgery stuff that we'll kind of breeze over. And then at the end, if you guys have questions, feel free to like chime in. I will also give you a caveat. You probably will not be seeing me here in the near future. I actually just took a job up at OHSU in the adult neurosurgery department.
What?
So yeah, so I'm actually going to be stepping out of the children's area starting, my last day here will be June 15th. So
Congratulations, that's awesome.
Thanks, yeah, but I'll miss you guys. You guys are my favorite department out of all the departments, out of all the people. Always loved coming and hanging out with you guys in the ED.
Well, we enjoyed you.
Oh, that's sweet. We'll miss you.
Yeah, all right, guys, so let's get going. So we'll kind of talk about epidemiology, anatomy, how to do kind of a workup, which a lot of you guys already know, some of the treatment principles, emergencies, common fractures, and then non-accidental trauma, which a lot of you guys already know. So we'll kind of go through this. Fractures for children compose of about over 10 million primary care visits a year. And I'm assuming that most of those come through EDs as well. And so you guys are seeing this quite a lot. And so that's why this is so important for us and for you guys to kind of be at least somewhat familiar with. Fractures constitute about 10 to 25% of all pediatric injuries. Boys more than girls. Who could have guessed that?
God, that's awful. 25% is not a lot.
Yeah, so, and here's a table. So the most common are distal forearm fractures, and then it kind of breaks down percentage-wise, you know, of what you guys would be seeing. But obviously the biggest ones are the forearm fractures. So this is interesting. So 82% of medical school graduates failed at basic musculoskeletal competency exams, which is why you guys are so important as a nursing staff. You know, a lot of these kids that come through just don't know as much as you guys know, just from sheer numbers of years of experience and just exposure. And so you guys are also like helping kind of combat some of the things that we end up seeing, and we'll go over some of those things. A lot of it's like splinting. A lot of it's just normal neuro exam. If you guys do a great neuro exam, it's very simple and yet it's so key, and we will end up kind of helping some of these kids out. So this is kind of the typical orthopedic surgeon, kind of what they seem to look like. I am not that. I am a skinny little Asian guy, and yet I'm still here, and I've been here for quite some time. So this picture I like just because it shows like how many different people, you know, in all different areas of life, how we need every one of you and every one of us to make sure that we treat these kids with the best care we possibly can have. So why are children's fractures different than an elderly person? Reason being, there's a couple things. There's the growth plates, and that's number one. The periosteum is number two. Ligaments, the physiology, and the bone structure is different between adults and children. So we'll go over some of these things. The bone anatomy is different because of the fact that you have all these different things. You have, in the small picture up on the right, it's a little small. The kids have this thing called a growth plate, or the physis. And the physis is so important because that's how a kid grows, and that's where they grow from, and that's where these long bones elongate from. And then the areas around that, you know, are just named differently. Epiphysis, metaphysis, the diaphysis, which is the long part of the bone, the periosteum, and the physis. But that's very key for what's different between kids and adults. So, about 20 to 25% of all skeletal injuries occur around the physis. And the reason that that's important is because you can have growth disturbance. And that can cause a kid to have an angled bone, can have a shortened bone, and both of those are not conducive for, obviously life. Everybody has a little bit of difference in their length of bones, but like if a kid has a growth arrest at a very young age, you're expecting that growth difference will be more than a couple of inches, and a normal person can adapt to in like a long leg to have about a 2 centimeter difference, which is about 1.5 inches. So it's very key to know like if an injury is through the growth plate, which both of these are examples of. In the ankle here on the side, you can actually see where the fracture lies that goes to the growth plate and through the growth plate, moving anteriorly. This one is the femur, and it actually has slid off, the kneecap has slid. You can see the kneecap out front, and then the epiphysis, which is this round thing, is actually slid forward, and then the diaphysis and the metaphysis is actually slid posteriorly, and so there's a complete disruption of that growth plate there. When we think about growth plate injuries, we talk about the Salter-Harris classification, and this is just for a way for us to know better description of where the injury is and what we're concerned about. And so we can go through each of these to kind of talk about each of them. So the first one's a class 1. Salter 1 means that there's an impaction and into the growth plate, and there's actually a sliding of this of the growth through the growth plate. 2 is a transverse fracture through the physis or the growth plate and out the metaphysis, which is this portion of the bone. 3 is through the epiphysis and through the physis. 4 is through both the metaphysis, physis, and the epiphysis. And class 5 is a crush injury, meaning that it's just kind of like if you think about like a peanut butter and jelly sandwich that you just sat down on, everything just kind of squishes itself down on. It's gross. So, most common type of Salter-Harris fracture is a type 2. So, a type 2 again goes through the metaphysis and through the physis, followed by a Salter-Harris 1. The problem with a Salter-Harris 1 is that you can't always see what that looks like on an initial x-ray, and that's why it's so important for kids to follow up with us in clinic about 1 to 2 weeks afterwards. So the highest rate of growth disturbance in a physeal injury is number 1 is a distal femur, which is about 50% have a growth disturbance. Second is the distal tibia, which is about 25%, and then the highest rate of growth disturbance is a distal radius. So when we look at those, that's why when we talk about femur fractures in kids, like it's so important for them to follow up with us, as well as tibia fractures. So when you think about anything, when you have a kid that has an injury to the growth plate in their leg, it's really important for you guys to make sure that you guys encourage them to follow up with us, and that's not something that they can just disregard and just follow up whenever, but we'd like to see them within 2 weeks of being seen here in the ED.
Can I see me walking? It's only like this.
The next thing that's really important and that's different between adults and children is the periosteum. The periosteum is this kind of fibrous kind of sheath that goes around the long bones and around the bones. And for kids, it's actually stronger than in adults. And so when you have a kid that has a displaced fracture, it can be held together by that sheath around the bone, and that's why we get why kids' fractures are different, and why we can actually accept some displacement and some translation of that fracture, and why we can cast them rather than having to put a plate or a rod down always initially, and that's why we like to try and cast or splint the kids much more often than we would in an adult. Ligaments are the other thing one of the other reasons why it's different in kids than adults. So the ligaments in kids are actually stronger than their bones. So when we talk about knee injuries, and a kid that is like, say, 10 years old has a knee injury that you would think would tear the ACL, because the ACL is stronger than the bone, what they have is what this bottom little x-ray is showing, which is called a tibial spine fracture. And what that spine is actually attached to the ACL. And so because the bone is weaker than the ACL, the ACL will rip off that piece of bone, and that's why it's as important that if you see a tibial spine fracture that they follow up with us, because it's still considered an ACL injury in a child, but it ends up looking different. And so that's why some people are like, well, why wouldn't you just get an MRI initially? In a kid that's younger, we can potentially see what we need to see with an x-ray and not have to have them wait a week or two to get authorization for an MRI, have the ligament, have that confirmed on there, because we already see it on a plain film.
Is the repair different with?
It is different, yeah, because all the surgeon does is then has to tack down that piece of bone down into the tibia, rather than you don't have to potentially reconstruct the actual ACL, because the ACL is fully intact. And 9 times out of 10 people, we've had kids that have been at, parents are like, well, we want the MRI anyways, and majority of the time the ACL is fully intact and you don't have to actually do anything with that. It's just a matter of actually getting them into surgery so you can actually screw that piece of bone down into the tibia and anchor it down.
So before you see any kid in your department as a referral, do you want a plain film?
We almost always do. The reason being is that 9 times out of 10, insurance will not approve any further imaging study unless there's a plain film, especially for an MRI. So if you guys have already done that, then we don't have to do that in clinic, and then we can kind of move the process along and get authorization for that. But again, it really depends on the thing. But 9 times out of 10, I always get an X-ray on a kid's knee, because if there is a bony lesion or bony abnormality, then it will most likely be denied by insurance to get any further authorization for anything, because they're like, well, that makes sense unless we have clinical evidence that we can say why we need something else, because on top of the bony issue, we also are concerned about this. But 9 times out of 10, we'll want the X-ray. Okay. So again, the physiology is different because kids' blood supply is different and they're growing, so there's more of a blood supply to the bones as well. That's the other reason why why a kid's fractures are different than adults would be. They have a higher rate of healing, and they have less chance of delayed union because of that. Okay.
Delayed union?
Yeah, so meaning that the majority of fractures should heal in this amount of time. Kids' fractures will most of the time will heal in that time. Adult fractures tend to have a harder time healing because there's not as much blood supply to the area. And so, yeah, that's meaning we would expect 4 weeks of healing, and the kid is only at 1 week. Very unlikely, unless there's some other metabolic issue or something else going on. So some of the benefits for kids is that they do heal faster, and that means that you can have a shorter amount of time of immobilization. Disadvantage being that because they heal so fast, that a misaligned fracture can become solid sooner, and that means that if we want to try and reduce something like this fracture showing, where this piece of bone has already started to heal in place, if you get to it too late, you can't do anything about that, and you would have to wait to kind of finish letting the bone heal, and then talk about intervening surgically later down the road. So bone structure, again, so there's things about kids' bones because they're more, I like to just say that they're more bendy. They're more flexible than adults. They can have things that we call buckle fractures and green stick fractures. So the buckle fractures, this fracture right here, where it almost just looks like a little speed bump on the bone, where when that impact happens, the bone is so malleable that it will actually kind of crush down on itself and just cause the buckle fracture. Another thing, they can also have the green stick fracture, which if you think about just like a young branch on a tree, it will bend and it will crack, but it won't actually shatter through that. The other thing that you can have is just plastic deformation, which is that you can actually see the bow of the bone, but no fracture is really evident when you were to actually zoom in on it. And so they can have these things that we would not have as adults.
And what do you do for that bowing?
So that same thing with the bowing, we would cast it and mold it. And
We'll
so
mold it, though.
yeah, so you would mold it.
So we would sedate these guys.
Under
and mold them?
sedation or?
So it depends. It depends on the parent. It depends on the kid. So most of the time you can sedate them. If a kid is like totally seems fine, and when you're pushing on it like a little bit, like because we'll always squeeze over the fracture site. If that kid's tough enough and the parents are fine with it, we will potentially just use like the intranasal fentanyl or just give them Norco and see how they do. But if the kid is like a very dramatic or very like scared kid, then we could definitely do it under conscious sedation. But it's kind of up to, that's why we like to see the kid, right? If you just always just say, well, every time we do this and we see this x-ray, it doesn't really work that way, as you guys know. Because a kid can be super strong and look really like a very easy fracture, and then as soon as you touch close to the fracture, then they're crying, and then it's too much. Right. But then you have a kid who's 10, and is happy and running around, and he has a broken arm, and he could have that same thing. So it really is a case-by-case basis. So, is this an acceptable alignment to leave this femur like this?
No.
It wouldn't seem so.
It
That
wouldn't
seems
seem
like
so.
over 20%.
Yes.
Half of that angle is
Definitely. So the reason we're asking this is because kids that remodel, if you look at the graph bottom here, so from the age of maturity, the remodeling process is actually quite high when they're very young. So if that kid is 1 year old, they can remodel and they can actually do okay. Now, if they come to our ED, as pediatric orthopedic PAs and attendings, we would not leave it like that. However, this kid could actually do quite well, and we'll see that in a little bit here.
So you would do nothing for it? You would
No.
just cast it?
So we would cast it, definitely. But we wouldn't necessarily have to fix that. Like, meaning go in and actually either put a rod or nails down it. We could actually cast that, mold it, and it would be okay.
How does that happen?
Without,
It's just like with humerus fractures. You don't generally repair humerus fractures.
Exactly.
But
Or
somehow find
or
their way
clavicle. That's the thing. In a kid in a femur fracture at a young age, those things, the bone naturally wants to try and find itself and become straight again. And so over time, that can actually pull itself back together and straighten out over time. And because that kid at such a young age has so much elongation of that bone to come over the next 16 to 18 years, they will remodel quite remarkably. And because of that fracture, they will actually overgrow, so you don't worry as much if it shortens a little bit. We expect that, but because of the robust healing of that bone, it will actually become longer than the contralateral side. So, again, like we talked about before, years of growth is always important. So if the kid is super young, we know that they have a lot more growth that they have. If they're older, then it makes us much more interested in intervening surgically. The position of the bone, is it near the physis? The nearer to the physis is better, because that's, again, where the bone is going to be growing from, and so that remains a good possibility for there to be more remodeling and more bone growth through that. Again, depends on the growth potential of the adjacent physis. Is it the upper or the lower humerus? The proximal humerus is where 80% of the bone growth comes from in the bone. So you want it to be higher up. You want it to be closer to the shoulder. And if it is, then we'll be much more conservative in our treatment plan. Okay.
So with all our supracondylars.
That's why I take them to surgery so much, is because there's not as much bone growth through the supracondylar area, and there's and because there's so much blood supply around that and nerves that we get more concerned about that area. So it's much more important for us to fix those than a proximal humerus. So here again is another femur. It's actually broken in two places, here and here, and over time it straightens itself back out.
They did not do any remodeling of that.
So any molding, no.
Any molding, right?
Yeah, so you keep it in that place, and then because of that immobilization, the kid can't move the leg, and that would be what would cause that continued movement of the bone. And so it naturally wants to be straight, and so it will pull off that extra section that is kind of anterior on that, and it will remodel itself to be straight. This takes a bit of time. This is going to be like over a year.
or 2. Okay, so it's not going to be like a short process, but this kid can start walking probably within 2 to 3 months.
Interesting. And that bone would be shorter? The one where...
No, so this one would actually be longer.
Would be longer.
Yeah, so we expect,
because
of that and because of the increased blood supply to the fracture site, the body's going to naturally start to grow more bone and encourage more bone growth through that. And so that we would expect that even if it's shorter initially, that bone would grow faster and longer in that. And so that's why we will actually see these kids long term further out. Same thing with the distal radius. Distal radius, this is what we call bayoneting. So there's actually shortening of that bone. And over time, the body will bridge across that fracture site. And then there will just be a natural little sweep of that bone. And if the kid's young enough, you would never know that was fractured in a couple years.
And again, no shortening.
No shortening, yeah. Or minimal. Yeah, minimal. So this is a proximal humerus fracture, 2-year-old, fell, was seen at an outside hospital, told to follow with ortho. You can actually see at 3 weeks out, you actually start to see new bone growth, and you actually are starting to see the humeral head start to come into play here. And you can actually see how much shortening there is. And at 7 weeks, you can see it's really starting to ossify in the proximal humerus, the humeral head, and the shaft is still hanging out here.
Oh my God.
And on a CT, you can see again how much remodeling is happening and how much shortening there is. But
you do no traction on that to pull that bone back into place.
You can try, but the body will naturally just start bridging as fast as it's injured. It'll just start healing itself. And so it's very hard unless you're right there and then there doing traction all the time. Sometimes what we'll do is do a hanging cast, and so that's why you'll see like us put like a really heavy cast bigger than we would normally do, or a long arm cast. And it's not because the elbow or the forearm's injured, it's just that we want the weight of that cast to pull down that arm, and sometimes we'll actually see that happen. So sometimes you guys will see that and it won't make sense, but it makes sense to us that that's what we're trying to do. If we see a proximal humerus early enough, we will potentially put a really heavy cast on that kid just to try and get that weight down and try and elongate it. So we don't need to go over this because this is more for primary care stuff, but these are always good rules. Getting a good history, ruling out non-accidental trauma. Is there a neuromuscular disease? Is there metabolic disease? Are there syndromes? Looking for deformity just by looking, because obviously you have your eyes for a reason. Palpate, palpate, palpate. One of the things I think is always concerning is do we take off the splint or not? I think as long as you guys can keep the arm somewhat in the splint, but remove the bandages so you can see the skin, look for the deformity there. If we never take off anything, then we don't know. We're only looking at an x-ray. And I think it's always important for us to always remove splints if we can. Because 9 times out of 10, outside hospital splints are terrible. And 2, we can put a better one on. And 3, we always want to look at the skin and just make sure that, hey, maybe there was a poke hole, maybe everything looks like it's aligned now, but we don't know, and we can't say that the skin is intact unless we look at the skin, okay? Check range of motion. Obviously, it's a little bit harder with kids, but always, as much as you can, check for the range of motion. Check motor, sensory, vascular, and then always check the joint above and below. That was one of the things that one of my profs in PA school stressed so much, and that has actually saved a number of kids for me over the years from big injuries. And so I always encourage you guys, if you guys can, just check the joint above and below. It's super easy to do. 9 times out of 10, they'll be fine, but every once in a while you'll catch a kid that has pain in one of those joints, and that's when you need to encourage the attendings or the residents to do further imaging if need be.
And that's mostly why you ask for the wrist film when there's a supracondylar.
Exactly. So that's one of the reasons why is if we do a forearm x-ray and we also ask for an elbow, the positioning of the elbow is different on an x-ray than if they do a forearm. And 9 times out of 10, they'll probably try and get the positioning the same. However, we still want formal x-rays of the elbow because the way that they are positioned and what they x-ray is just different than when they do a full forearm x-ray. All right. So CT scans are important for occult fractures or operative planning. So sometimes you guys will wonder why, like if it doesn't look like it's very, very big, or we're concerned about something like a Liz Frank injury, which is the joint space between the first and the second metatarsal bases. So we need a CT because we can actually see if that bone is pulled off, and it's a very small thing, and 9 times out of 10 we can't see it on x-ray other than maybe a little widening on that. So we'll do that for that. We need MRIs for ligament and cartilaginous injuries or stress fractures. And so when we're kind of thinking things up or we're worried about certain things, this is kind of the general rule for why we're looking and ordering certain imaging studies.
What is a stress fracture exactly?
Stress fracture, so when you think about like runners, and so kids that have shin splints, thank you. So what's happening is that repetitive impact over that tibia is causing little fractures through that, and you can actually see that on an MRI where you couldn't see that on a CT or a plain film. Sometimes you'll start to see periosteal reaction, but an MRI will guarantee you to be able to see if there's a stress fracture or not in that. Okay.
And you can't see periosteum on an X-ray, can you?
You can see periosteal reaction on an X-ray, which is like you'll see next to a bone, you'll see these like little wisps, almost like it looks like someone was shading in with a white pen. You'll see these little lines on the side of the long bone, and that'll be the periosteal reaction. Yeah. So we see that a lot in non-displaced fractures. Or those like green stick fractures, something where it's like it's not a true fracture where there's going to be a huge callus formation around it, but the body's naturally, even though it's straight, it wants to support that area, and so you'll start to see that periosteal reaction. So obviously, this is where you guys come into play. Kids that look like this, where they have an angled arm that doesn't look like it's supposed to, and then they'll come through, and then we'll reduce them with your guys' help, and they'll have a straight arm again. So splinting. So I like this because this is like really, it's simple, but this is what we would need from you guys and from the ED. Hand and wrist fractures, we want a volar splint. Make sure that, I've had a couple of kids that have come to me over the years, and they've had splints that actually end at the fracture site. So please check the residents' splints, because if the fracture ends at where the splint ends, it's not really supporting it. And so really important, like, and you guys are like have been here long enough to know, if you look at the x-rays where things are. For forearm fractures, we like sugar tongue or a long arm posterior splint. Same thing with an elbow fracture. We like a long arm posterior splint. We don't really use sugar tongs as much for elbows, but prefer more the long arm posterior splints. For foot fractures, short leg posterior splint, ankle fractures, you could do a sugar tong and a posterior splint, or you could do a posterior splint. Knee, we want either a knee immobilizer or a long leg splint.
What is a sugar tongue again?
Sugar tongue is this U. So what it just does is just goes around and just kind of immobilizes it that way. So it's also called a stirrup on a long, so you'll hear those things. So yeah, that's all that is.
Because I hear that term, but I just don't know what it means.
Yeah.
And you always want to immobilize the joint below and above.
If possible. So if a kid in a long bone, if it's closer to one joint, at least immobilize that joint. Okay.
But if it's like the wrist or the ankle, you don't need to do a long.
No.
Just.
Yeah, exactly. Yeah, unless it's like a kid, like a 1-year-old who doesn't know how to stay off of it, then we would want a long leg cast to try and kind of hinder them from being able to walk on it.
Make them clumsy.
Yeah, exactly. This is reduction kind of techniques. So I don't think you guys are going to be doing much reductions. And this is that surgical stuff that we were talking about. So as far as emergencies goes, we'll move into this section. So open fractures are always an emergency because of the fact that it's open. Look at it. Like, there's not something, you can't just put a splint on that and tell them to follow up with us. For risk of infection, for risk of neurovascular compromise,
And is there a difference between what is more open than other things? Like
Absolutely. So when we talk about a poke hole, usually it's a type 1 where there's like, if you were to look at the skin, you would see like almost as if like a poke hole, like it just kind of went through the skin and went back in. So that's a very different thing than like an open fracture like this one, right? So that one is still technically open, but it becomes less of a concern, but it's still something that we would need to see, okay? The more important part for us is time of that they got antibiotics, because we need antibiotics on sooner than later. So when you guys are looking at kids that have come from outside hospitals, figure out what time they got their last antibiotics, and if they haven't, then we need to get that on board.
And is it always ANSEP? Is that the first? Or
That's usually what we go with, but it depends. Like it depends on how dirty the kid is. But typically that's what we'll go with. Compartment syndrome is another thing. So when a kid has this much of a comminuted fracture, we really worry about the compartments being soft. Okay, so that's another reason why we want you to take off the splints and actually like check the skin. So actually push on the skin, which it can really suck for the kid. But if that is hard as a rock, then that should be a red flag for we need to like force the ortho resident or the attending to come see this kid sooner than later. It's not something that can wait till morning, but that's why we want, like, again, to take off the splint, and why we want you to check the skin, not only for the open part, but also to check the compartments, just to kind of see. They will obviously be swollen, but a kid that has a rock solid compartment in any area around that fracture, then that's a red flag for compartment syndrome.
So, years ago when I worked in trauma, we would check for compartment syndrome. We'd use an art line setup.
Yeah.
And they would put a needle, like a big 18 gauge needle, Gelco needle, and we would just stick it into wherever, like their calf or their thigh.
Yeah.
And then we would read it just like an art line would, but we'd zero it and then zero it at the level of the calf, the art line setup, and then we'd stick the needle in to the calf, and then I forget what the magic number was. Like when we
it's usually 70, I believe. I can't remember if they're still keeping it around that, but we have one.
What do they do now to check for compartments?
They will do the same thing. We have it. I think it's in our resident call room that they have that. They have the needle and the device to check everything. We haven't done it for. I think in my 4 years I've seen it done one time, or I've heard of it done one time, and that was the only time. It's much harder. Like we don't see it as much in kids, but it's one thing that we do always check, because for that one kid, if we miss that, then that kid is like neurovascularly like compromised, and then we're kind of SOL on that one. So it's that, but that's why we kind of go through the same thing every time. Check the compartments, check the skin, do all of that. Obviously, vascular injury, neuro injury, and neuro deficit is also one of the emergencies. So we'll go over some of those things a little bit later. Femur neck fractures are always a huge concern and always an emergency, because the blood supply to the neck of the femur is very is minimal, and so we want to make sure that if that's happening, the kid is A, not walking on it, and B, we get to see them as soon as possible. Skiffies are the other thing. It's not technically a neck fracture, a femur neck fracture. It's actually through the epiphysis. Again, that's through that growth plate through the.
So what exactly is a skiffy? Like I see it in obese kids, 12-year-olds.
Yep.
That's what I see it in.
Yeah.
Can you explain it more?
Yeah. So what this is the femoral head actually is the epiphysis right here. Is this thing that I'm circling? That slides off through, like the physis actually is weakened, and it slides off because of the weight of the child. And so then that whole thing slides off, and then the rest of it, the metaphysis, is kind of hanging out there. And so the reason that obviously that's so important is because the kid's going to grow through that, and because of the fact that you walk on this. And so a kid who walks on this is going to damage that growth plate and will likely have a pain and have impingement because of that, and will have limited activity. And like you said already, this is in an obese kid, and so they're not going to be active, and so they're just going to get larger, and then they're going to have other complications because of that.
And the only way to repair that is through an operation. And what actually do you do? It seems
You
like
put a screw through
Oh, a
the,
screw. Okay.
screw through the neck and try and hold it into place. You
Into
can't.
the epiphysis?
Yeah, through the pivot, through the metaphysis, epiphysis, and through the metaphysis. So all three, you're trying to hold that into place. You can't reduce it. They've done studies, and it's debatable whether or not they reduce it. But they, in our practice, typically, we're just trying to hold it so it doesn't get worse. So this kid is for acute unstable, and we'll go over that a little bit later, what the unstable means. But that kid should be on bed rest, and they should not be walking. Okay. Most common fractures: distal radius, supracondylar, clavicle fractures, skiffy, tibia, and femur fractures. So we'll kind of cruise through some of these. So distal radius fractures, we can accept up to 20 degrees of angulation. So sometimes it looks worse than it is, and we can actually take a fair amount of angulation. However, as best we can, we like to straighten them out as much as possible, and that's why we are doing so many conscious sedations and so many, so many reductions in the ED, because we want to have the best outcome if possible. We always, again, get an elbow x-ray. The reason being, again, like we talked about, joint above and below. And a kid who has a distal radius fracture can also have an elbow fracture. And then we have it's much more concerning, because then we have two joints and two or three bones that we have to kind of immobilize. Again, we want to look out for the same things: abrasions, numbness, tingling, hand pain, elbow pain. Again, that elbow pain is what we're concerned about, is that floating elbow. Because if there's a wrist fracture and an elbow fracture, then that whole middle section is just kind of out there by itself. So to be able to immobilize all of those things is the most important. This again is a picture of that poke hole. It's still technically considered an open fracture, and that's why we still need to evaluate it. But it is less of a concern, but it is still something that we need to evaluate to see if we need to wash that out. So what to do when we're talking about deformed, numb, or open fractures? We want to they are here, and then we want to evaluate them to see if we need to take them to surgery, and who else needs to be on board with that. If it's not deformed but displaced, potentially we can splint them and see them in ortho, or even something like this on the top here. We would still want to try and do a reduction. Okay. So this is they did a large study looking at distal radius fractures that ended up being displaced and bayoneted like this. And bayoneted means that they're still in line. So if you were to draw, if you were trying to figure out if there's any angulation, there really would be very little angulation. So if you were to draw a straight line looking at both of those pieces, they would still be in a straight line, just stacked on top of each other. And what they found is that they did this in Hawaii, in kids that in Hawaii. And what they found was that those kids actually ended up doing just fine and remodeled without actually any intervention. So it's not necessarily an emergency for that kid to be reduced. If we see them and they're already 2 to 3 weeks out from that, likely we will not do anything about that, and we'll just watch them. And we'll see in a couple slides, there's a sequence of what that ends up looking like.
Wouldn't the bayoneting be pretty unstable to try to reduce, and then wouldn't it?
Yeah, very much so. And so that's why, so even the kids that we reduce, sometimes with that they will still end up being bayoneted after that. And then we'll see that. Okay. So a kid who has a distal radius that's through the physis, this would be considered a type 2 here. We'd still try and reduce that because it's through the growth plate, and then we would cast them. If we don't get to them, if we fail to reduce it the first time, we cannot do it again because it's through the physis. And once you've damaged that, you would potentially continue to injure that, and then you guarantee that not guaranteed, but you have a higher rate of growth arrest because of that. So we have one shot to do that, and that's why we try and get that done as soon as possible. And if we can't, then the kid we just have to continue to observe them and see how they do long term. Again, this is a bayoneted kid, and then we reduce that.
Can I ask?
Yeah, absolutely.
Is reducing a fracture more technique or strength? Or both?
Good question.
Great question. It's a bit of both. I've seen really good reductions on kids that have been done by little Asian women that are residents, and they were the best ones, and it's about their technique. And if that kid has already started to heal, it doesn't matter how strong you are or your technique, because you're fighting the body from doing it, what it's really trying to do, which is heal itself. So it's a little bit of both, and that's why, like, if it's done early enough, it can be done and by anybody. That's why I can do it sometimes, and other times I can't. So yeah, but great question. So 10 days, presented 10 days after the fracture. We could not do a reduction because it already started to heal. You can actually see how much callus is starting to form over that fracture site. 6 months later, that's what the kid looks like. Other than a little bow, doing just fine.
Now, you sometimes re-break.
Sometimes.
In what cases do you re-break versus just let them remold? Or
If the angulation is great enough and the kid is physically deformed enough, then we would potentially do that. But we wouldn't do it till later. But that's typically why. So this kid would still, like, he would be close to that 20 degrees, maybe a little bit more. But you kind of have to watch and see how that goes. But that's why at 6 months, if that kid still looked like it was really cocked back and that kid's arm was like really kind of messed up looking, then we would potentially have them follow up with one of our upper extremity specialists, and then they would potentially re-break it. If a kid is chubby enough and that looks okay without, like, if you just look at the arm, sometimes you can actually the arm looks perfectly normal, but when you x-ray it and it has a curve, we wouldn't do anything about that unless that kid is having functional issues, and then it becomes more of a functional issue. Operative treatment: inability to get acceptable alignment, open fractures, displaced intra-articular fractures, soft tissue injury, meaning that, like, there's that compartment syndrome that we talked about, associated fractures, so the floating elbow that we talked about earlier, and if there's any kind of like open fracture, that would be as well.
Can I just, this is probably a stupid question.
No.
But when you have to re-break a bone, okay, do you do it by hand or you take like a mallet and smash their...
No.
Well, you know, like when
We'll
you
do a
break
saw.
your nose.
We'll do a bone saw, and we'll actually saw it and then, like, realign it.
Linda
Oh,
wants to come
okay.
in there
Yeah.
and hit him with a mallet.
But I mean, yeah. All right, so we'll keep going here. We're about halfway through. So supracondylar humerus fractures are 9 times out of 10. This is what we would call a type 3 supracondylar fracture, because it's a through and through fracture and it's completely displaced. When the arm looks like this, where you can see how much bruising, how much swelling is in there, that won't by itself, like, kind of get better, and so we actually have to try and actually get that back into place, and put pins through that in order to help that get back into place. Elbow fractures are about 10% of all fractures that kids have. The important part is early recognition and getting them to us and referral to us. We've had a number of kids that have come from outside facilities that had supracondylar fractures that they thought that it was a dislocation and have been tried to reduce it. Never let somebody try to reduce a supracondylar or a lateral condyle fracture in the ED because of the concern of the vascular and the neuro structures in the elbow, because you can see how jagged those things are, and if you try and reduce that inappropriately, you can you can either puncture the nerve, or you can impinge that nerve into that space, or you can hurt the vascular structures there. So an important, I learned Credo for the sequence of the ossifications. This is another one. Come read my tale of love. And so this is important because a lot of people will get sent here or sent to us because they think that there's a fracture, and it's actually an ossification center that's actually just growing because of the kid's age. So if you guys can understand what is supposed to be growing and when, and you can look at, like, how old that kid is, and kind of pair that to the X-rays, you can actually educate outside facilities and yourselves to, like, what is a fracture and what is actually just a growth area. So don't have time to get through all of that, but it's important. Sam, do you have a question?
Well, yeah, I'm confused. I don't understand. So you're saying that sometimes you can look at a normal X-ray and confuse it for a fracture based on their age and the way they're
So you
based on their age and the development of their elbow at that age.
Correct.
Sometimes you can misread that and think it's a fracture.
Correct. So in like say a 1-year-old, you're going to start to see that this is the capitellum. They started to form in. So if for some reason you a 1-year-old comes in from an outside facility, they say they have an elbow fracture, but you actually just see that the capitellum is where it's supposed to be, and it's just floating there, but it's actually just ossifying in. It becomes less of a concern. Does that make sense?
Yes, it
So we get a lot of kids that they will see like the medial epicondyle forming in, and they think that it's an avulsion fracture, but it's actually just the that's actually just kind of forming in. So they'll be splinted, or they'll be packed into splint, and it will be inappropriate for that to happen.
Because you always think it's like a little floating bone on the side.
Exactly.
Like,
So a lot of times they'll call an avulsion fracture on somewhere in the elbow, and it's not actually the case.
oh, cool.
So important for the neuro exam. This is like kind of one of the greatest things you guys can do. If you can get a kid to do rock paper scissors or give you a thumbs up, an okay sign, and spread out their fingers, give you a high five, 9 times out of 10, that's like a quick, dirty neuro exam that almost every kid can do. And if they are able to do those things, then we know that they're neurovascularly intact. Caveat being, if a kid gives you a thumbs up, but they can only kind of bringing their thumb up a little bit, that's not actually what we're looking for. We're looking for them to actually fully raise their thumb up and give you a really good thumbs up. Same thing with the ulnar nerve. If the kid can only extend their fingers but not get it to a neutral, and they couldn't give you like a true high five, that's a very different thing. And we want to see them actually be able to fully extend all their fingers. Okay? When we're checking the sensation on a kid, there's 3 areas that we, if you guys are looking for if they have sensation. One is the web space in the thumb, on the top of the thumb, the web space there. One at the tip of the index finger, and then one at the tip of the pinky. And if you do those 3 areas, then you've checked all the nerves and you know that they have sensation. Okay? So that's like a quick and dirty thing. Rock, paper, scissors, and then web space of the thumb, the pointer finger, and the pinky. Okay? If you guys do that 9 times out of 10, we know that they're neuro intact. Okay? Cap refill, I just check every finger, and if they have good cap refill, then you know that everything proximally is doing fine. Okay. When we look at X-rays, a lot of times for non-displaced fractures, just elbow fractures, we'll see that there's what we call a posterior fat pad or posterior sail sign. That's the one we're really worried about. The front one is pretty common in just every elbow, even if there's not an injury. But that posterior kind of black area right there, if you start to see that, then we know that there's an elbow injury, and then that's grounds for either It's just that the effusion into the elbow will just kind of swells, and that's kind of the area that it kind of shows up in.
And then, so in the front, when you have a fat pad in the anterior aspect of this supracondylar area, what is that? Means nothing.
It's just kind of a normal area that will be fluid. Like, so when you think about when you flex your elbow to about 90 degrees, there's a little bit of give in that area, and so because of where the biceps tendon inserts, it kind of allows for a little bit of a pocket of space in that area.
So it's just behind. Okay.
Yeah. So just really looking for that last one. If you're like, kid's having pain, and you get the elbow X-ray, the lateral is one of the more important ones for us. X-rays, we always want an AP and a lateral, so we can check for those things that we're most concerned about. Okay. Again, we'll skip through some of this. These are the types of. This is the classification for what we define at supracondylar. Type 1 supracondylar means that you just have that posterior fat. You might see a little buckling or disruption here in the posterior cortex of the bone, but otherwise, mainly everything looks like it's where it's supposed to be. And that kid can be splinted and does not have to be urgently seen by us, and then we can follow up with them in clinic. Type 2 is hinged back, and you can actually see that if you were to draw a line through the front aspect of the humerus, that little round thing, this is the capitellum. that line would not kind of bisect or hit that capitellum. If that's the case, then that's a surgical case.
Because the normal one, you should be able to.
Yeah, so if you look at this first one, if you were to draw a line, trace a line through the front aspect of that bone, you would actually cut through at least the anterior third of the capitellum, that round part.
Because I've heard him talk about that before.
Yeah,
Is
so
that-
that's what we're looking for.
And then isn't there something based on the radius of the ulna coming back through it?
Yep, perfect. So that's the other thing. So the radial, if you were to draw a line up the radius on a true lateral, you would actually, this radius should bisect the capitellum as well. So that's kind of, yeah, and so when you cross those lines, everything should cross through that capitellum. Okay. Type 2 and type 3s are surgical. So there's always a type 1.5, and that's always a debate.
1.5.
A 1.5 meaning that it kind of is buckled back, but for me, if it still cuts through the anterior third, then we will consider that non-operative, and we would cast that though, rather than just letting it be splinted if we can. So before we can get to them, if we're seeing them in the ED and we have to transport them up to do surgery, we're not doing it right away, we still want them splinted. Do about 20 degrees of flexion. That usually seems to be the most comfortable for a kid, but as they're comfortable. So we don't want it too high. We wouldn't want it at 90 or even close to 90, just because then you can worry about impinging some of the vascular and the nerves in the elbow. So we'll put pins in, we'll do long arm casting for 3 weeks, we'll pull the pins, and then they'll start working on range of motion at that point. Okay. I'm going to kind of breeze through some of this so we can kind of get to clavicle fractures. Clavicle fractures, 9 times out of 10 we don't do anything about. We, especially in a baby, have a hard time with some of our scheduling staff because they hear that it's a baby, that they want to intervene, but we don't actually intervene on these. The most that you would do is you would potentially safety pin the kid's arm to their like onesie or something like that. But a kid at an infant age, if there's a fracture, they go through a thing called pseudoparalysis, and so the kid won't move that arm and that extremity until that bone is healed enough, and then all of a sudden they'll start moving their arm, start moving their leg. So they by themselves will not hurt themselves, and so there's less that we would have to do with something like that. Even in older kids, we don't actually do too much unless they are an athlete that actually is like a football player or a soccer player, or uses that arm like for a throwing athlete or something like that, where they would actually need us to intervene so that they can get back to their activities, or if it's an open fracture, obviously. Okay.
What would you do? Like surgically put
a plate through it. Yeah, so you'll put a plate like that across that and just kind of line everything back up. So this is what we're talking about. So this kid, you just safety pin that arm just so the kid doesn't have to try and hold it up, and they can do that. But this is not an emergency. This is skin tenting. But if you start to actually see that bone is starting to break through the skin, then that is considered true tenting. Okay, this would just be more considered a prominence over that clavicle, and this kid will do just fine. All right. So most of the time, put the kid in a sling, and that's all we would do. Families have a really hard time with that. They think that we should.
To clarify, for a clavicle fracture, assuming that they're not into sports and it's not an open fracture, we never do anything?
We would sling them and just follow them out as an outpatient. So moving on to the skiffy. So we talked about this a little bit earlier. Common problem, like we talked about earlier, is in males that are obese, prepubescent, and there's a higher rate in Polynesian patients. So the reason for, again, this is a mechanical insufficiency of the proximal humerus through the physis, and that's a problem because the load of the lower extremity is through that area. So the things that we get concerned about is there endocrine factors, is there previous radiation therapy, renal osteodystrophy, and obesity. So those are the 4 main reasons why we see this. We care because of AVN, avascular necrosis, and degenerative joint disease for those things. So when we talk about acute versus chronic, it means that they've had symptoms for less than 3 weeks. Chronic means that they've had symptoms for over 3 weeks. Acute on chronic means that they've had for over 3 weeks they've had symptoms with increasing symptoms over the last 3 weeks. Okay. Stable versus unstable means that they have been weight bearing. This is not a test for you guys to do. It means that if they came into the ED, were they walking or were they not walking on it? Never test the kid to try and walk on it if we're concerned about the skiffy. They should be. It should be just based on their history. If that makes sense.
So is it okay to sit them up, or do they need to be?
No, they can sit up. We just don't want them actually putting weight down on that leg. So one of the other things, and this is one of the areas in which I've seen this happen. A kid will come in with knee pain, and we'll X-ray the kid's knee, and we'll never do anything about the hip. And this is why sometimes I will get a pelvis film on a kid that has knee pain, especially if they fit the criteria. If they're an obese little kid and they're having knee pain, and they're having when you try and range them, they won't move their hip or their knee. Always try and get them to get a pelvis X-ray, because if for some reason you miss that, and then that kid ends up going on to have AVN or a joint degenerative joint in the hip, and then we missed it, then that's shame on us. Shame on us for doing that. And I have actually caught 2 skiffies over the 4 years with a kid who had knee pain for weeks and never complained about hip pain, and it just got a pelvis X-ray, and then lo and behold, it had a skiffy. And it was in a kid. And so even if a kid doesn't fit if they're a white kid who's not obese, the worst thing you could do is say like, well, they're not a Polynesian overweight kid. I've seen it in a girl who was not overweight and she was a white girl. So just be concerned, and if it's a red flag, if you have that gestalt, which we know you all have, and you have concerns, get the X-ray, or at least try and see if that's something that we've thought about. So we get 2 views of the pelvis too. Never just get one. On the frog leg view, which is the lateral kind of the other view that we get on an AP, and then a frog leg lateral, you'll start to see this slipping that will happen, and this is like kind of the pathology of how it will progress over time.
And a skiffy isn't something that is familiar or hereditary or runs in the family, anything?
It can, but there's not it's not like a surefire, like, oh, if there's family history, or if there isn't, then we wouldn't get an X-ray. So yeah.
So the other night I had a kid come in and I thought it was a skiffy, and I ordered but I never knew if I ordered it right, a complete pelvis.
Yep, perfect. Yep.
And that'll give you the frog.
Complete will be an AP and a frog.
I didn't think we could do pelvis.
Well, let Sam Baloo click the button. I can order anything I want, as long as the doctor later on says, I agree.
Yeah, and so that's
the treatment.
Yeah, and so that's the treatment. Put a screw right through the whole thing. Yeah. And this is like a really unstable one. So you can actually see that thing is all the way down and around. And that has a high likelihood of going on to having AVN, but we still need to try and fix it the best we can and stabilize it. So this is a 4-year-old came in with on the AP. You can actually, it's hard to see on it because it's blown out a little bit. Actually looks fairly normal if you were just kind of breezing through this. And the reason for getting the lateral and the frog view is that you can actually see how far that thing is actually off. That thing should actually be up here. Okay, so that's why don't just get an AP, get an AP and a frog. It's always better to have 2 views just to make sure we don't miss something.
You do that.
It's not to get you a complete. That's what a complete pelvis is.
So this is all fixation of that. Okay, we'll move on to tibias here. So tibia fractures, one of the higher level reasons why we'll see kids. Frequent injury. What becomes operative is an open fracture, a polytrauma, unstable, and an unacceptable reduction. Okay. a lot of these happen, these little spiral fractures, and we call it a toddler fracture, but it's a distal tibia spiral fracture. A lot of times what we'll see is the common story will be I had my kid on my lap and we went down a slide. And the reason why that happens is because the sole of the shoe will get caught on the side of the slide, and then it's a twisting injury, and that's why it's that spiral that happens. And so as a kid goes down, because there's so much more force, because there's an adult with them, it actually just kind of twists that tibia and elongates it and breaks it. So never go down the slide with the kid. Just let the kid go down on their own. Tibia and fibula fractures often occur together, and so it's not unlikely to see a tibia and a fibula fracture together. Again, it's that twisting motion that we just talked about. Most of the time, we won't do external fixations anymore. That'll be usually in older kids, but we can likely, our practice here is mainly more to do flexible nails or rods, depending on the kid's age. Again, looking at the nerve, the pulse of the toes and the foot and the compartments to check and make sure that they're soft. Again, we want 2 views of the tibia, depending on, just so we can get, again, 2 views, and just to get a 3-dimensional aspect of what that fracture looks like. Because if you just get 1 view, and I don't think we can even order just 1 view here, but that's why we do it, because sometimes, again, you can see something on 1 view and it looks completely normal in another view. Again, we want less than 2 centimeters of shortening, which we talked about earlier on the long bone of the leg. Acceptable difference in leg length is 2 centimeters. We want less than 50% translation, meaning that like when the bones are stacked on top of each other, if only 50% of the top part of the fracture and the bottom are on, we actually want more than that. So if that's all we can get because the periosteum's to crap and we still want to try non-operative treatment, we will. That's why we want them to follow up so frequently with us in outpatient. Again, we want less than 10 degrees of angulation again as well for that. We talked about toddler fractures. Again, always be concerned that there might be child abuse in that. It should always be something that we cross off the list. I know our team here, like you guys are great at that, but just one of those things, just never make sure that the story fits the fracture. And if you're like, it just doesn't seem right, or if you just have that feeling, just make sure like we've kind of parsed out everything that we can do on those. Likely what we do for these kids is do a long leg cast. We do it non-weight bearing, but if it's a kid like this kid will start walking on this in a week. And we're okay with that because, again, the kid's not going to walk on a fracture that is unstable or hurts them. So again, if it's displaced, if it's swollen, or there's a high energy, we'll want to see them and want to see them here in the ED and make sure that we don't want to do a fixation on that kid or do something more than just cast on them. Femur fractures. These are. This is going back to what we kind of talked about earlier. It's not. When you look at these numbers, it's 1.5 to 2% at the most. We rounded up to peds fractures, but it's a reason that it's a reason for us to be seen by ortho and not something that like you guys would just splint on a kid, because we have to put them in, like I think you guys have seen, like a spica cast. The spica casts suck, but they really help with putting that kid in the best position. And I'll show you this. I like this. So this is a kid who's in a long leg, and why we want them. The spasticity leads to extreme angulation, and what we mean by that is if that kid continues to flex that leg and move that leg around, that will cause that leg to continue to tighten up and kind of flex down on itself, and that's why we have that angulation. So that's why, like for an older kid, we would actually put rods down that, because we know that 9 times out of 10, even if you keep that kid non-weight bearing, that kid's still going to move that leg, and every time they move that leg, the quad muscle is going to fire, and it's going to continue to kind of push that into an angulation.
Okay, so you don't use the weights anymore on them?
We do sometimes. It depends on if we want to do something operative, and that's up to the attending and above my pay grade. So for the spica cast, I'm going to scroll down to these little pictures right here. The reason this is cool, so this was that kid earlier that we saw that we were like, gosh, it's not an appropriate angulation. But over time, that kid will actually straighten itself back out because the bone wants to naturally be straight, and the body will naturally pull itself back together and straighten itself out over time. So the angulation deformity will remodel significantly in kids under 5, and that's why we can do more with less. So if we put that kid in a spica cast, 9 times out of 10, that kid will do just fine by putting that cast on and just immobilizing that kid. Things that can't correct are rotational and malunions. Will not correct, and that's why when we talked about earlier about healing, that bone doesn't heal, the body won't naturally do anything about that, and so we have to intervene. Okay, and that rotational thing. So if you try and put a kid and their foot's up and it should be out to the side, you have to correct that. And so if it's a completely mangled leg where the foot's pointing in the wrong direction, we do have to intervene on something like that. So Pavlik harness we can do in a kid that's under 1 and it's not walking, or under 6 months. Spica cast for a kid that is over 6 months, and then internal or external fixation for older kids. This is kind of the options, plating or rods. Most of the time we'll do rods or flex nailing, which is this first one.
What's flex nailing? Can you go back to that?
Yeah, so they're flexible nails that you can actually push down through that you would actually pull out. So in a kid that's younger, we would actually do that because we can remove the hardware. But in a kid that's older, you wouldn't actually, they were not strong enough to hold, and so that's why we would put the rod down on an older kid because you would treat that more like an adult. So here's that algorithm that we just, yeah.
So 0 to 6 is Pavlik, 6 months to 6 years is spica. So 6 years is the magic number.
Yep.
We go to surgery beyond that.
Yeah. So non-accidental trauma is always a concern for us. Obviously, it is for you guys as well. But we have to treat everything with that it's serious. Abused children face a 50% risk of re-injury. And that's a sad statistic, and so that's why we want to kind of make sure like we're not if there's a fracture that doesn't fit the story, or you guys just have concern based on how things are in the room. We want to make sure that we're checking out all of these things, and especially because of this number, 10% risk of mortality without protective service initiation. And those are just sad truths about kind of where we're at. And so we just want to make sure that we're doing everything we can for kids. So you guys, talk about this. So sorry. So rib fractures, we always get concerned about abuse, and femur fractures and humerus fractures, tib-fib fractures under 18 months. And why is that? The reason is because kids that are typically, if a kid isn't walking, they shouldn't be breaking their leg, unless they're rolling off the bed or things like that. But a kid doesn't usually like. The femur is the hardest bone to fracture, and that's why it's like always when we see a kid with a femur fracture that's young here, it automatically warrants like us trying to work up an NAT and trying to see that. Kids with like those, and as they kind of grow up, you kind of see like it could be possible that it could be accidental because the kid at 18 months is a little clumsy and it's not walking as well as a kid that's older and more developed. So it is possible. Tib-fib fractures happen all the time. However, if it doesn't seem right to you, it probably isn't right. But at least you can rule it out. Okay. And then again, we can just kind of look over these kinds of things. A kid who has 0 factors, risk factors in here, under 18, history of suspicious story, physical, radiographic evidence of a prior injury. low likelihood of abuse, higher and higher and higher as we get up to 2 to 3, okay? So here's kind of the conclusion for it. Sorry we ran over, guys. Pediatric fractures are common.
Good class.
The physis is key. Always check the anatomical reduction, but it doesn't have to be anatomical. And because a kid's age, depending on how old they are, they have a tremendous ability to remodel. Always check neurovascular, check the joint above and below. Emergencies are always open fractures, compartment syndrome, neurovascular demise, femur fractures, acute skiffies. Yeah, look at the arm. If the arm looks deformed, then it's definitely going to need to see us. Skiffies are always serious, non-weight bearing, and then likely what we'll do is admit the kid. Clavicle fractures, no, even as grotesque as sometimes they can look, they're not an emergency unless they're open. Toddler fractures, always check x-rays, make sure that there's, see if they're normal. If the kid refuses to weight bear, high likelihood or high suspicion of a toddler fracture, even if you don't see something, even if it's on an AP and a lateral, have them follow it with us in a week and splint them. And you can always rule out an infection. Make sure, if the kid's been healthy otherwise, then splint them. If they're not, then check labs and see if there's something else going on. Femur fractures, if they're not walking, rule out abuse. Okay? And that's it for me, guys. Sorry I ran over.
Oh, no,
Okay.
it was a
Just
great
out of
class.
it.
One question, I might have missed it, because I wasn't here when you first began.
Yeah.
To bivalve or not to, what is the determination? How much manipulation it is to get it back into place, or,
It
well,
is.
I know, but what determines whether you're going to, because some don't bivalve and some do.
Yeah, so that is attending dependent. Some will actually univalve, some will bivalve. It really kind of depends. I actually very infrequently would bivalve. I would usually univalve it, meaning just one cut.
One cut.
But depending on how it goes, it really ends up being kind of dealer's choice.
So it doesn't have anything to do with you having to, like, it was really hard reduction and you had to really manipulate it?
Not necessarily, yeah.
Oh, okay,
Yeah.
okay.